This is just
Wait for 1 or 2 more minutes.
Hamrit?
और 1-2 मिनट वेट कर लेते हैं.
Okay. Can we have once again, it is my pleasure and honor to welcome you all to this episode, 109th episode. Happy Onam to all of you. Today we are going to discuss a very practical aspect of rTMS, how to set up, how to work with rTMS, what is the evidence around it. So we have two very good speakers with us today. Next slide, please. I'm handing over the session to Professor Dr. Tufan Pati sir. He is the organizing chairperson of this program and our leading light. Sir, over to you.
Thank you very much, Dr. Alim. And I welcome everyone to this 109th episode of Custom Musings. And happy Onam, as Alim has told everybody. Onam that brings prosperity, that calls up north Mahabali, the great king, and let divine blessing be bestowed upon everybody. Next slide, please. Dr. Amrit Patjoshi is a moderator from the very beginning. He is well known. He is professor of psychiatry in High-Tech Medical College, the direct council member of IPS, and a vibrant member of IPS. And next, Dr. Alim Siddiqui from Lucknow. He is the treasurer of IPS, quite rich person, having the IPS treasury with him. He is professor of psychiatry in Eras Lucknow Medical College, and he had been a direct council member earlier, and he has got many publications to his credit. Welcome, Dr. Alim. Both are vibrant moderators. You will see them in action very soon.
Thank you, sir.
Next, please. Our chairperson.
Next slide, please.
Yes. Dr. Kaustubh Chakravarti from Kalyani, West Bengal, the chairperson, is associate professor and HOD in JNM Hospital, Kalyani, Nadia, West Bengal. Is life fellow of IPS, convener of IPS Research Education Training Foundation Subcommittee, honorary secretary of IPS West Bengal State Branch, nodal officer of DNHP, Nadia. He has received a number of awards. Just to quote a few: Sarda Menon Gold Medal in DNB Final Examination 2010, Fellowship of Japanese Society of Psychiatry and Neurology India 2011, and Dr. R.B. Davis Duration Award in 2021. He has got 9 book chapters and 27 papers in international journals and 40 papers in national journals to his credit. With this, we have got Dr. Kaustubh Chakravarti. Please welcome him. Next slide,
Thank
please.
you, sir.
Dr. Pavan Kumar from Karim Nagar, currently professor and HOD of psychiatry in AIMS Karim Nagar. Number of publications 10. Membership also honorary secretary of IPS Telangana State Branch, convener of IPS Specialty Section on Private Secretary, and areas of interest: consultant liaison psychiatry, ECT, and child psychiatry. With this, I have the pleasure to hand over the further proceedings of this musings till we start discussions to Dr. Pavan Kumar and Dr. Kaustubh Chakravarti. Please take over. The meeting is yours.
thank you, sir. I hope I'm audible, sir.
Yes, you are audible.
Yes, sir.
Just introduce Dr. Tika.
At the outset, I'd like to thank Dr. Tufan Pati sir, Dr. Alim sir, and Dr. Amrit Patjoshi. And this is 109th episode of Thursday Musings, and I think this is the longest series that is possible in the history of IPS. So it's my pleasure being here, and I take this moment to introduce today's speaker, Dr. Sai Krishna Tika, who's from Hyderabad, who is associate professor and in charge HOD of psychiatry department at All India Institute of Medical Sciences, BB Nagar, and he has 73 publications out of PubMed Index 64, and he has also written around. He has also authored 21 chapters in books. He is associate editor currently at the Indian Journal of Psychological Medicine, and is on the editorial board and invited peer reviewer in international journals. He is a member Indian Association of Medical Journal Editors. And awards, he has received a Marfatia Award of Indian Psychiatric Society in 2020, Pune Psychiatrist Association Award Indian Psychiatric Society in 2019. He was conferred a Young Psychiatrist Award in 2018. And he is the recipient of Bhagavat Award, Indian Psychiatric Society in 2016, and Pune Psychiatric Association 2 Award in again in 2016. And he is also recipient of a BPSS Award, Asha Award, and MM Murugappan Award of Indian Psychiatric Society in 2014. His areas of interest are psychosis, neurodevelopment, cognitive neuroscience, electrophysiology, and non-invasive brain stimulation. I welcome Dr. Sai Krishna Tika.
Thank you so much.
Next slide, please. Next, I take this moment to introduce the next speaker, Dr. Shobit Garg, who's from Dehradun. He's professor and Sir is professor and HOD at Department of Psychiatry at Sri Guru Ram Rai University. He's an alumnus of CIP Ranchi. He is a chairperson IPS Neuromodulation Committee, and is also convener social media subcommittees of SARC Affairs. And membership, he's co-chair IPS Suicide Helpline, and he served as past secretary Uttarakhand State Branch and past convener of Social Media Cell IPS 2020. He is also executive council member IAPP UP Uttarakhand, and is a member editorial board of IJPM and reviewer in various national and international journals. His areas of interest are bipolar disorder and brain stimulation. Research and publications. Sir has created of 65 plus publications in national and international journals, and he has also authored 14 book chapters. He is also recipient of paper which won BPSS and Tara Naidu Award in SIPCON 2021, and he has also co-authored papers which won Pune Psychiatry and Murugappan and Marfati Awards at ANSEPS. I welcome Dr. Shobit Garg, sir.
Thank you, sir.
Sir. Costa, sir.
Yeah. Thank you, Dr. Pavan. I'd like to thank Dr. Tufan Pati, Dr. Alim Siddiqui, and Dr. Amrit Patjoshi for inviting me in this edition of Thursday Musings. It is the 109th episode, as I've learned, and it is one of the online program which have the highest TRP probably in the history of IPS, as Dr. Pavan has already said. So today's session is on rTMS. As a associate professor in psychiatry and now a teacher of postgraduate trainees, I would like to say that this will be a very interesting session for the new learners, particularly those who are doing post-graduation in psychiatry. Still, I would say rTMS is very much underutilized because of lack of its availability in most of the medical college, barring some premier institutions and barring some psychiatrists, quote unquote, who are very affluent psychiatrists who can afford rTMS in their clinics. It is very much underutilized. However, it is an emerging field in psychiatry, neuromodulation, rTMS, direct current stimulation, and other form of brain stimulation techniques. rTMS has been used in depression, OCD, mania, schizophrenia, substance use disorders with some efficacy, although that has been inconsistent largely. But there are quite a good evidence in the field of in depression, I would say, and in some cases of treatment resistant or poorly responding OCD patients. Apart from that, there have been some sham control studies where the results have again been inconsistent. Some studies showing efficacy and some studies showing a result which is similar to placebo. So the efficacy of rTMS in different psychiatric disorders is still to be proved beyond any doubt. This would be a great learning session for all of us listening to from Dr. Sai Krishna Tika and Dr. Shobit Garg, those who both of them are very knowledgeable in the field of neuromodulation. So without any further delay, we can start the session now. Thank you.
Thank you, sir. So I think with this outset and a wonderful introduction by Dr. Pavan, and my regards to the organizers, I think if I am allowed to share my screen. Is it visible? Am I audible?
Audible and visual.
Thank you. So thanks to Dr. Tufan Pati sir and Dr. Alim sir. They wanted us to do this last month, but we wanted some window to actually make it
पर गुस्सा है
more
क्या?
make it more pragmatic and more meaningful for the audience, learned audience in this platform. So we have divided this presentation among myself and Dr. Sai. So what I'll be doing is I'll be just sharing some evolution, then some basics of how to establish the clinic, what all things we require. So many people must be having an aura around rTMS and the setup that might go off at the end of the presentation. Some clinical scenarios in which then it will help you out in selecting the rTMS from a clinical process point of view. And then Dr. Sai will take over from the evidence, the current evidence he'll be sharing. So with this, I'll also like to disclose that I don't have any disclosure or any conflict of interest, though I'm working with McVenture MacPro machine in our institute. So coming to a very basic thing, what International Neuromodulation Society, as per them, what is neuromodulation? That is technology impacting at neural interface. And it has n number of names. So this neuromodulation, rTMS, comes under this broad umbrella of neuromodulation, where it inhibits, stimulates, modifies, or regulates the via electrical, electromagnetic, or chemical stimulation to central peripheral autonomic nervous system. So this is the whole gamut or basket of neuromodulation. And where we are concerned with today's presentation is this electromagnetic or magnetic stimulation, where myself and Dr. Sai has worked extensively. Just some anecdotes, historical anecdotes, that it all started, electrical stimulation in a live brain in an eroded tumor tissue, started in late 1874. And it was published. Subsequently, around the same time, maybe a few decades later, there was a lot of experiments going around by D. Arsenal. And what he did was he tried to actually stimulate these phosphines by stimulation of this occipital lobe. And then these visual spectra were formed. And then they subsequently came to know, by the help of the magnet, they can actually stimulate the brain. So therein came this Faraday's principle. It is, it's very easy. I'll just make it very easy. So when you have a varying electrical current in an coil, so it results in variation of a magnetic field, and these varying magnetic fields subsequently would induce electric currents. And if we consider these wires as neurons, so these wires have an induced electric current. So without actually breaching the barrier, so this becomes there is a neuronal stimulation or neuromodulation, and it becomes an invasive painless procedure. So, in around 1950, psychosurgery went down, and by then there were a few movies like Cuckoos Around the Nest, and it actually brought a lot of stigma to the psychosurgery, this ice-picking surgeries and all. ECT went downhill because non-procedural the treatment options were vouched for, and also anesthesia procedures were very cumbersome. So subsequently, parallel to this, the first magnetic pulse device was invented by Barker and colleagues, which was known as Sheffield magnet. So this was an event in 1976. Now, with this, some historical anecdotes, I would like to just have everyone's attention on very, very important. I think this is the most important part of the presentation, is basics of rTMS, because if you don't get this, the whole presentation goes for a toss. So, a sound of a click is one pulse. So try to make it like this. So this is one pulse. So when you when you ever encountered with an rTMS machine, there is a button. When you press it, single pulse, there is this sound. So when you have these five single clicks together in 1 second, it becomes a frequency of 5 hertz. So that is simple mathematics. Now it is followed after some interval. Same thing repeats, like 5 pulses in 1 second, that is 5 hertz. So it becomes 2 trains. So there are 2 trains which are separated by an interval, which is known as intertrain interval. So this is the whole basic, very simple machine physiology. As far as these pulses, this jargon of this terminology is concerned, and we all can communicate after this subsequently. So when we talk about 1 hertz, it is known as low frequency, and more than 5 hertz, it becomes high frequency. So 5, 10, 20, this becomes high frequency.
So now these are very basic patterns. These are very basic patterns like low frequency, high frequency. Subsequently, recently, more complex patterns of stimulation have come up. We might not go into the details of these. This is theta burst stimulation. So here, what happens in theta burst? So these are bursts of very high frequency, 50 hertz frequency. They are actually given in intermittent manner. So it becomes intermittent theta burst. But counterintuitively, intermittent theta burst is activating. And this CTBS is these small bursts are given continuously, and this becomes inhibiting. So as in this high frequency, and this is akin to high frequency activating, and CTBS is equal to low frequency rTMS, like 1 hertz rTMS is inhibitory protocol, and ITBS or high frequency rTMS or ITBS, we call it activating protocols. So this is the basic. So when we talk about how to set up a clinic, the pragmatism of it, this very important is we should know who is a TMS physician. So TMS physician is person who is trained or at least have credentiated training in rTMS. So there are a lot of institutes providing that in our country. We can discuss in question answer sessions. And the person should be a neurophysiologist or a neuroscientist, like psychiatrist, neurologist, or neurosurgeon who has a residency training in these fields. And this is important that, and this is different from TMS operator. Operator are those technicians who can at least recognize potential serious changes in patient's mental status and alert the attending physician, like someone throwing a seizure, someone having a switch, manic switch with rTMS, which is reported. So this is a TMS operator and TMS physician. So let us be very, very clear regarding this. Now this is our setup. So what should be an ideal TMS room? So we can see it should have a very good AC, and this is our rTMS unit. It should be airy, and these are two EEG technicians, and this is Mr. Srinivasan, our CIP alumni. He's a psychiatric social worker, and he implements rTMS. So this is a machine, this is a unit, this is a trolley, and this is an rTMS delivering unit, and this is a coil, coil tubings, and this is a coil with coil handle. So this is the chair, and there are a lot of chairs with pillows or which to make patients head position very comfortable. This is the we are using McBencher model R30. This is the front version of it, and this is a socket where these are coil tubes, and socket is put into this one. And our machine only allows one coil at a time. There are many upgraded machines which allow more than 2 coils at a time also. And when we see closer look at this coil, this is around 1 crore 80 lakh pulses are there. We can deliver with this coil. I'll share the cost analysis later on, and it is valid for 1953 days. After this, the coil will expire. And this is the coil surface. This is an active coil surface, and the opposite side of this coil is sham coil surface. So with one coil only, we are doing both the stuffs. So this is just few things about these machine parts. Now, what is the most important thing is when we do an rTMS is one of the key components is how to calculate motor threshold. I'll just give it a shot because it is very easy in a workshop kind of a thing. So what we do is we will actually try to mark the vertex by anion to union and by preauricular sulcus tag both the ears. This midpoint we have tried to mark it here. So with this midpoint, what we will do is we will go 5 centimeter lateral to it, and this is known as motor hotspot area. And here we will try to stimulate the brain in order to elicit the motor thresholds. And why this area is selected? Because this is the most highly excitable area of the brain. So this is the motor area, motor hand area. So the coil placement should be tangential to the scalp, or from a sagittal sulcus, it should be at the angle of 45 degrees. So when we see, when we calculate this motor threshold, we have to have this MEP monitor, which is placed at the back of our machine, and it should have an EMG wire with EMG electrodes. And this is the screen of Mac Pro, where this is the amplitude, motor threshold amplitude, which can be increased by this button here. And these are various settings. And when we click, when we give a single pulse, there is a wave which would be displayed here, and we have to calculate motor threshold via that. And there are various algorithms for that, which will not go into the detail, like Rossny-Rothwell algorithm, etc., etc. So, but if many machines don't have this kind of an facility, we can go for this visual contraction of FDI muscle or abductor pollicis brevis muscle, and we can actually calculate the motor threshold, but the motor thresholds will not be very accurate. Generally, it will be on the higher side. So supposedly, I got this 70% of the motor threshold, 70% of the threshold, this visual contraction of the thumb started. So what I will do is, if I am stimulating at 70%, so it becomes a threshold protocol. If I am stimulating at 80% of 70 or less than 100% of 70, it becomes sub-threshold protocols. And if I am stimulating at more than 100% of 70, then it becomes supra-threshold protocols. So that is how this terminology or the jargon is understood. So before progressing to any rTMS, we have to have this rTMS checklist, which was given by Rossi et al. And we can this is freely available, and we need to see it that from every dimension, what are the precautions, which we'll be discussing in later subsections of the presentation. And if we find some issues with the checklist, there's some confusions, so risk benefit analysis is always done. So whether to progress or not. Now coming to some clinical scenarios. Mr. Ganesh, 35-year-old, this clinical scenarios might help you in choosing rTMS as a treatment modality. Married, middle socioeconomic, a businessman, well-balanced PMOD personality with hypertension, diabetes, and hypothyroidism, and occasional alcohol use, and family history of paranoid schizophrenia in mother. Now, this Mr. Ganesh, after father's demise, he went into a phase of depression, where the patient was given adequate trial of SSRIs, SNRIs, and TCAs, but resulted in poor response and also tolerability issues arised. Subsequently, adequate CBT sessions were given, and patient continued to remain non-responsive. So, citing non-tolerability and also poor response, it was planned that why not an rTMS shall be given to Mr. Ganesh. On these are hypothetical case scenarios, and we selected high frequency left DLPFC, that is dorsolateral prefrontal cortex. And evidence Dr. Sai will share, and we gave this because of the required evidence we had, and which will be shared by Dr. Sai. Now, after this stimulation, many people have actually come out with maybe some anti-psychiatry movement, neuromodulation people, that it doesn't do anything. It's just an sham kind of a stimulation. But many studies have now established that there is an increase of genetic expressions of CFOS and ZIF268, which are the neuronal markers. And interestingly, CFOS also increases after sham stimulation. And there is a trend of increase of BDNF in patients who have shown improvement in depression per se. Also, when we gave this rTMS, the Mr. Ganesh went into the baseline. His problems resolved, and he improved. Now there was a question that whether are we stimulating DLPFC, so improvement is happening at DLPFC? No. So it was found that DLPFC improper connectivity with medial frontal, medial temporal, or other areas of default mode network were involved. And it was pointed out in this study that actual changes were happening from to remote areas rather than at DLPFC. So that is what this interesting study had shown. Now with this, in continuity of this case scenario, Mr. Ganesh, who turns 40, now comes to us subsequently because he has a history of paranoid schizophrenia in mother, with complaints of suspiciousness, hearing voices, third-person auditory hallucinations, preferential delusions, and negative symptoms started to come up. Then patient was given adequate trial of FG and SGS, and again poor response and tolerability issues arised. ECT initial good response was shown, but subsequently developed cognitive side effects. So the patient and guardian refused to consent. Then what happened? Again, rTMS was planned for Mr. Ganesh, and we chose low frequency protocol to left temporoparietal cortex, specifically for very, very disturbing auditory hallucinations. Now, Dr. Sai will discuss this evidence. We did this as per the evidence base. which was a little poor, but I think I'll leave it to Dr. Sai to express it in more coherently. So what happened subsequently after this stimulation of low frequency rTMS to left temporoparietal cortex for auditory hallucinations, patient didn't show any response or minimal response. So we were in soup that what we should do. So what we did was we tried to look for other sites. So we went for other regions. Like one of the region was, you would think this is a small brain. No, this isn't cerebellum. So we found that cerebellum, limbic cerebellum, the midline part of the cerebellum is associated with cerebral cognitive affective syndrome, including psychosis. So we tried to actually stimulate this midline limbic cerebellum 1 centimeter below the inion. So what we did, me and Dr. Sai was involved in the study, that we did it we studied in one case, and we found that there was spectral changes were found in frontal lobe and left temporal lobe, and the patient improved clinically. So it actually showed us, no, this might be something which has some substance. So we planned RCT, and we gave a similar protocol in the form of an RCT. So we found that negative symptoms and depressive symptoms significantly improved over the course of 1 month with this protocol in a randomized manner. So what happened subsequently? Then negative symptoms and depression improved, but transiently. And again, Mr. Ganesh started to worsen after some duration, because the improvement was short lasting. So what we thought is, okay, let us then go for a more stronger protocol version of it, that is theta burst, which I explained initially. So theta burst was subsequently planned by us. We published this study in a treatment resistant schizophrenia, and we give ITBS. ITBS, you remember, it is a high frequency protocol, and it's an activating protocol. So we try to activate cerebellum. And the neurobiology behind it is that when we are giving an activating protocol or ITBS, it results in long-term potentiation. Long-term potentiation means your pre-synapse will be activated within 100 milliseconds, and it will activate post-synapse. So first pre-synapse will be activated, then post-synapse will be activated. And this would result in increase of PKC and calmodulin modulin kinase 2, and which will increase in result of influx of calcium flow, and will incorporate more NMDA receptors in the post synapse. So you can see the synaptic density has increased, and synapse become more strong, and long-term potentiation happens. Now, what we do is, similarly, when we talk about CTBS or low frequency rTMS, long-term depression takes place. Very easy to understand. First, your post synapse gets activated, then pre-synapse within 100 milliseconds. And here there is a small and slow flow of calcium ions, and to the contrary of long-term potentiation, where there is high flow of calcium ions. So what happens there, we'll not go into the details of it. There are different neurobiology of each and every receptor in LTD, like AMPAR, NMDAR receptors. So again, we will not go into the detail of it. Now, interestingly, this was a paper which was published by us. What we did was, we actually tried to see that whether this LTD and LTP, by application of these theta burst protocols, whether this actually takes place. So we give it in childhood schizophrenia. Surprisingly, what we saw was childhood schizophrenia brains were more prone for depression or cortical inhibition than cortical excitability. It was a crossover design. So that is what we found, and we published it subsequently. Now, coming back to our original study, where we thought that we'll give theta burst to cerebellum, we didn't find any improvement, sadly, possibly because it was a short duration protocol and there was a lack of neuronavigation. Now, why there is a requirement of neuronavigation or navigated TMS? So we can see that this was the vertex, and 5 centimeter lateral to it, we made out this as a motor hotspot for motor threshold. And when we go 5 centimeter anterior to it, it becomes DLPFC. So when we stimulate DLPFC, we are doing with this rule. This is 5/5 rule, or it is around F3, sorry. So what happens is, when we actually do it with an MRI guided, or which we call as neuronavigation, we found that these were inaccurate localizations. and it was it actually underpowered this F3 F4 rule or 5 centimeter rule which we shared. So that is why neuronavigation is desired for precise localization of brain regions and precise delivery of stimulations. Now, one more issue with TMS is subsequently, if we see this, that in treatment-resistant depression, now they are saying that subcallosal cingulum is implicated. Now, how to stimulate this area? Because you can only stimulate the brain from the surface. So it is around 6 centimeters. So what we have to do is we have to go for deep TMS. Now, what is the concept of deep TMS, which is very, very important? The many companies have come up with this 8-shaped coil. And when we see this 8-shaped coil, so any coil, when there is an increase of depth, the focality goes for a toss. So jitna deep stimulation hoga, utna hi kam focality hoga. So what happens? We can see this figure of 8 coil. It is the stimulation area, the electrical field area is not very deep, and it is a very small area. But when we go in for this figure of the double cone coil, so we can see that the depth of electrical field is increasing, but it's also it is more widespread. So the focality is compromised. Now a recent deep TMS, there are H coils have come up. This is available in CIP, and this H coils will result in very deep stimulation, but you can see a very diffuse area is involved. So how we expect a specificity in stimulation? So they have come up with this ferromagnetic coils, which can actually narrow down the depth of stimulation. So this is the concept of the coil's nature and the focality and the depth. Now coming to some safety issues which are very, very important, and this is a very, very important thing. This is expressed in an article by Rossi et al. That we explained train. So train was that the group of pulses. So they have limited the durations of the train. So if the frequency is 1 hertz in one train, you cannot have more than 1800 seconds of stimulation. So they have made these broad guidelines which needs to be followed. But companies, the machines, they don't have they have not bothered themselves to these safety limits. So they have 10 to around 15 times more pulses you can actually deliver by the help of those machines. Now coming to another safety issue in pregnancy. If pregnant female comes with the psychosis or depression, refractory issue, whether we will give rTMS? Yes. So rTMS is safe now in pregnancy, and we have successfully reported, I think it was we managed to publish it after around 10 or 12 failures. So we did it for refractory dissociation in a patient who was in a first trimester, refusing medications and therapy. And we stimulated this patient in right temporoparietal junction, which was involved in impaired self-agency. Now, coming to the other safety issues. So implanted medical device that is ferromagnetic or magnetic sensitive, or any such metal objects in the brain, head and neck areas are contradicted with rTMS. And also cochlear implant shall not be used with rTMS. But safety is assured for pressurable programmable valves to treat hydrocephalus, cardiac pacemakers, DBS leads, which are subcutaneous, VNS systems, spinal cord stimulators, which are 10 centimeter away from the coil, can be given safely. Now, important is operator safety. So operator should maintain a distance of 40 centimeter from the coil while stimulating the rTMS. Now coming to last 2 sections of my presentation. Now, if we know that rTMS is an in thing, so FDA has approved, though FDA is not the whole and soul holistic body, but FDA had approved rTMS for major depression in 2008, and cortical mapping for neurosurgeries in 2009, migraine with aura in 2019 for acute and prophylaxis for acute treatment also. So someone having a first trimester pregnancy, you cannot give any NSAIDs, you can give rTMS. OCD, smoking cessation, anxiety comorbid with MDD has been approved as a part of deep TMS. Now, importantly, this is very important in Indian context, is machines are approved for these indications, not as if rTMS is was approved. So, and sadly, there is no Indian machine which is involved in this approval system, and we don't have our approval system in this regard. And this is very important because many of the clinicians who might be practicing in this presentation, attending this presentation, they might be using a lot of Indian machines. So I don't know what is their experience about it. Now, this cost analysis I have done, many people will say ki nahi ji, Indian machines, why will take? They are very costly. So if you buy an rTMS unit with theta burst, the theta burst is the most advanced form of stimulation. So it will cost you around 25 lakhs. We can always argue that. And it comes up with two coils with 2 crore pulses each. So 1 crore pulses each. So overall 2 crore pulses. So if we give 2000 pulses per session, so I'm going a little extravagant. So 10 sessions per patient becomes 20,000 pulses. So in this process, we can actually deliver 1,000 patients can be delivered in the machine's lifespan. So if we charge 250 rupees per session, so we will be actually breaking even the cost of the machine, the foreign, the machine, good machine. And if we charge 500 rupees per session, we'll be actually getting the income double the cost of the machine. So the cost of the machine. So this is how a cost analysis may suffice. So there I will end my presentation, and I hand over to my very dear friend Dr. Sai for the second part of the presentation. Thank you.
Thank you so much, Shobit. Dr. Shobit spoke about the use of rTMS, the practice, how to set up a rTMS unit, then the basic neurobiology of it. Then he spoke about how we utilize different paradigms that are there in rTMS through a case-based approach. I will take up the evidence part, which is not really experience-based, but then based on clear-cut evidence from randomized controlled trials and several meta-analyses that have been conducted on these randomized controlled trials. More importantly, I would take this opportunity to share the Indian evidence on the use of rTMS, very importantly, and then I go later on to practice recommendations. A small disclosure: this part of this presentation is based on recently conducted series of systematic reviews and meta-analysis by our team, wherein along with me, Dr. Alim, Dr. Amrit, who are the moderators there, in Shobit, Dr. Sangamitra from Ranchi, and Dr. Manasvi Gautam from Jaipur. We are all involved in these sets of meta-analysis that we conducted. There are no conflicts of interest. Have worked with MaxTeam equipment. Received no financial aid. All the figures and tables that I'm using in this presentation are original. So like I've told, Indian evidence, initially I'll deal about a bibliometric analysis of the Indian evidence, and later on go to the meta-analysis, especially the safety and the efficacy evidence that we have. And then I go on to share the practice recommendations, the most recent practice recommendations that we have formulated. We conducted an umbrella review, so I'll share the results of that particular study. So, how many studies from India have come up in the field of rTMS? So, we searched various search engines like PubMed, Web of Science, Scopus. We found out roughly around 145 publications are there. We might have missed one or two, but then we have a total of 145 and was August. So till we had around 145 publications. First publication happened in the year 1999. To me, it was a surprise because I thought it must be somewhere, it must be either NIMHANS or CIP that might have published it first. But instantly, the first report was a diagnostic study wherein rTMS was used to see corticospinal excitability in children with malnourishment. So that happened in 1999 from Banaras Hindu University, BHU. From psychiatry is a case report from NIMHANS where Dr. P.N. Gangadhar and his team reported a case of seizure with single pulse in a case of bipolar disorder. That is in 2005. From then on, the rise has been, the trend is rising. So the R square, which we found out, is around 0.8. That means the trend is further rising. Last year, we had around 19 publications on rTMS. This year, hopefully, we'll be crossing 20 as well. So out of these 145 publications, the most of it are research studies, or case series or case series. The most of the next is around letters, which include research letters too, and mostly case reports, which are around 26%. And then we have around 8 review articles and a few case reports, otherwise also published. So what's important is, about 25% of these publications are for funded research. So we get adequate funding also is available. But then what's important is, 75% of these publications are not for funded research. So even if there is no funded, if the institution can fund a bit, if the equipment is available, it can definitely be conducted. Such studies can be conducted. So we found out that out of the 145 publications, the majority studies were conducted on schizophrenia, then depression, then obsessive compulsive disorder. What's important here is in this bibliometric analysis, it's not only therapeutic TMS, but then diagnostic, the TMS being used to analyze various neurophysiological functions have also been included. So anyways, schizophrenia, depression, followed by obsessive compulsive disorder. So mainly psychiatric disorders, then later on followed by neurological disorders like movement disorder or migraine. Even stroke falls somewhere around 9th position. So these are the different diagnostic groups in which Indian research on rTMS has been conducted so far. The top 10 institutes with the number of publications, as expected, National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore, leads this list. Second being Central Institute of Psychiatry, CIP, Ranchi. Then All India Institute of Medical Sciences, Delhi. King George University, KGMU, is also conducting several studies on rTMS. Then SGPGI, Sri Chitra. There are other such institutes, that are conducting studies. 7th position is Guru Ram Rai, which is Shobit's institute, and kudos to him that a private institute is, doing such research studies and coming out with publication outcomes. Authors, this is a co-occurrence of authors, and the strength of each author in terms of publications comes up with this most viewer. We find out that Dr. B.N. Gangadhar, Dr. Thirathali Jagdish, Dr. Urvaksh Mehta from NIMHANS is the major group that is working in this particular group, followed by Dr. Nand Kumar and Rohit Verma from AIMS, Dr. Nishant Goel from CIP, Dr. Samir Praharaj from Kasturba Medical College, and of course myself and Dr. Shobit are on this list. Predominantly the studies that the journals that have taken up these research articles, predominantly the Asian Journal of Psychiatry, followed by Brain Stimulation Journal of ECT, which are prime journals in the field of rTMS. Now, once we understood that there are 145 studies related to rTMS in India, we went ahead and conducted a meta-analysis of intervention studies. So we found that there are 52 studies which are intervention. So 32 of them are randomized control, sham control studies, and the others are non-control studies. And we conducted a meta-analysis using a series of random effects model. And then what we found out here, what I would like to give you a summary of this meta-analysis, but not going into a lot of detail about this. So we found out that majority of studies have included schizophrenia, followed by obsessive compulsive disorder and depressive disorders. The contrast with the existing global research is that there is tremendous amount of research in the area of depressive disorders, which is little in contrast to what is happening in Indian studies, wherein the majority of studies have chosen schizophrenia patients for intervention trials using rTMS. Then there are significant, a good number of studies on migraine, substance use disorders, mania, panic disorder, fibromyalgia, and also chronic tension headache and essential tremors. We have included fibromyalgia in this meta-analysis because most of these cases do come to a psychiatrist, and also they have this opportunity to, if they have an rTMS machine with them, so it's an opportunity for them to actually use rTMS in these cases of fibromyalgia, which are we consider them as somatoform disorders. 39 studies have used conventional high or low frequency stimulation. Dr. Shobit told you about what is conventional high and low frequency stimulation. Very importantly, 13 studies, it's a significant number when we consider 52 in total. So 13 studies have investigated the effects of theta burst stimulation, either intermittent theta burst or continuous theta burst. What's important to note here is that all studies except those on migraine have used rTMS as an adjunct. In studies with migraine, what they have done is they have given a washout period of around 15 days for whatever drug they are on, and then later on went on to give rTMS for prophylaxis. Apart from that, all other diagnoses, like say starting from schizophrenia, depression, substance use disorders, obsessive compulsive disorder, rTMS has been used as an adjunct. So what we need to understand is the evidence that we are seeing is for rTMS as an adjunctive treatment rather than an complete single form of treatment. So like Dr. Shobit mentioned, we have machines which are foreign made, and then we have machines which are Indian made too. Out of the all these machines that are there, FDA has approved 3 machines. So Maxim, MagVenture, and Neurosoft. So majority of the studies in India have also used Maxim, MagVenture, and Neurosoft. There are 2 studies which have used Rebenure and Medicaid. Medicaid is again commonly used by most of the practitioners in private practice. And there's no regulation as of now in India, but then we hope that it will come up one day. That there is a regulation of rTMS equipment in India as well. Otherwise, they form of kind of follow the international standards. These studies, majority of studies, have used conventional figure of 8 coil, like we expected, but then 2 studies have used H coil. So H coil, the research on H coil has begun recently. A study from NIMHANS, 1 study from CIP. They have used H coil and used for deep brain stimulation in cases of obsessive compulsive disorder and depression, I guess, respectively. And 1 study has used a double cone coil. That was our own previous research, where we stimulated cerebellum, deeper parts of cerebellum, using the double cone coil so that it reaches much inside. I'm sorry. Yeah. So the conventional targets. So Dr. Shobit spoke about conventional targets, and then the rest novel targets. The conventional target, which is the dorsolateral prefrontal cortex, which is identified by the common 5 centimeter rule, was stimulated in majority. Around 26 out of 50 studies have used that. Supplementary motor area, especially for obsessive compulsive disorder, there are 6 studies that have used. Orbitofrontal cortex has been targeted by 4 studies. Temporoparietal cortex, especially for auditory hallucinations in schizophrenia. Cerebellar worm, 3 studies. Then anterior cingulate cortex, this is the H coil. The dorsomedial prefrontal, again the H coil. These are these deeper structures which are also targeted in these studies which are conducted in India. So 3 studies have used bilateral stimulation. Like Shobit told you that there are systems which have where we can have 2 coils together, and there can be bilateral stimulation, or the stimulation can be given one after the other 2. So there are 3 such studies which have used bilateral stimulation. Of all the studies, most commonly the method that is used for localization of the target stimulus is the 5 centimeter rule, which Dr. Shobit told, which is not really precise, but then that is what is most commonly available, because we don't have other neuronavigated systems here. But then better than 5 centimeter rule is the international 1020 system. If we follow the international 1020 system of electrode placement, where around 16 studies have used that system for target localization. MRI neuronavigation has been used by 4 studies, and SPECT-based neuronavigation has been used by 1 study in Indian studies. So, quite a lot of neuronavigation is also happening in Indian studies, Indian research too. So overall, the intensity of stimulation that is being used is 70 to 120. So both the supra threshold and sub threshold stimulations have been used quite effectively too. Number of pulses that are delivered per session have ranged between 500 to 3000. Like what Dr. Shobit told, around 1800 pulses, 1200 pulses is the safety limit. Commonest is 1200 pulses. So this is a range. Then no one has gone beyond a particular threshold and stimulated regions. And majority of studies have used once daily sessions. So there's something called intensive stimulation, wherein more than 2 sessions can be given in a single day. So the number of pulses per day increase, but the number of pulses per session may remain small. So there are 3 such studies, and this is coming up. This particular intensive stimulations have coming up of late. What does the evidence say? Firstly, I will talk about the safety. Like Dr. Shobit also told you that it is safe, but then how much safe? So there are serious adverse effects. What are the serious adverse events that are related to rTMS? One is seizures. Second is affective switch. These are the 2 most important serious adverse effects that occur with rTMS stimulation. And we find out that both of these are quite infrequent. So the percentage of the occurrence of seizures in Indian research on rTMS or effective switch is less than 0.5% for each. So that means, 5 per 1,000 participants. So here you see the N of active stimulation. People who have received active stimulation is 1,065, and those who have received sham stimulation are 565. So out of the 1,065, there are only 5 subjects who have had an effective switch and 4 subjects who have had seizures so far. So that's quite small. So we can clearly say that it is quite safe. While on the other hand, the chances of non-serious adverse effects are quite common, not really uncommon, but they're called non-serious because they are transient. They can be treated very easily by using some NSAIDs, etc. So commonest is headache, which occurs around 9% of cases, and then followed by scalp discomfort or facial pain that occurs, to combine together again around 9% of these cases. So, what's important is that if there is any discontinuation with the adverse effects that are occurring. So commonly the discontinuation, all the 4 cases of seizures and switch had to be discontinued. That is how the protocol is done. And the other commonest feature that non-serious adverse effect, if we see, then headache or scalp pain have resulted in 7 discontinuation out of the 16 total discontinuations. So that is an important thing to note down. So serious adverse effects are very rare. Commonest adverse effect is headache or scalp pain. In terms of efficacy, we divided the efficacy in terms of 2. We estimated the efficacy rates in terms of 2. One is active only, those who received active stimulation pre and post, if there is a significant change or not. Then second is sham control. If we compare the sham control improvements are the significant in active group. So what we found out, I'll give you only the conclusion of what we found out, because meta-analysis is quite cumbersome to understand and it is quite lengthy too. So in the active only sub-analysis, we found out that significant effect of rTMS for all outcomes. So what all outcomes we saw? Depression in depression, then for schizophrenia, we saw, positive improvement in positive symptoms, negative symptoms, auditory hallucinations, overall psychopathology. We saw, depression, not only in unipolar depression, but also bipolar depression, post-hoc depression, peripartum depression, So, and then headaches, substance use disorders, we saw craving, we saw manic symptom improvement in mania patients too, OCD, obsessive compulsive symptoms in OCD. So for all the outcomes we studied, there was significant effect of rTMS with moderate to large effect sizes at both end of treatment as well as at follow-up. So this is very encouraging, kind of result we had. But when we did the control analysis, so active versus sham analysis, so we found out that except for migraine, the headache, both headache in severity and frequency, which showed large effect sizes at the end of treatment only, not at follow-up. So there was immediate effect. And then craving and alcohol dependence, where there was moderate effect at follow-up, not initially. So it's an interesting thing. So rTMS, except for these 2 conditions, migraine and alcohol dependence, rTMS was not found to be effective for any of the outcome. So this is the analysis that this is the result that our analysis found out. So these are the forest plots that we did for the analysis. What we can see is that the black rhombus, which is a pooled effect size, often is shifting the midline. So that means that there is negative values as well as positive studies. That means that significance is not statistically very important. But however, our analysis, what we can understand or conclude is that it is still inconclusive, that we say no, it's not that we say there's no efficacy, so we don't go ahead and do more studies. So it's inconclusive and needs more studies, because the number of studies in each meta-analysis is quite small. There was significant publication bias that we found. There was significant heterogeneity. This on the right, what you can see is the risk of bias assessment, where we found out more than 25% had unclear or high risk of bias. And the sham control positive result, whatever we got in migraine and alcohol dependence, lost significance when these high risk studies were excluded. So that's sensitive analysis. So when we did that, the significance lost. So what we can understand is that there is a need for more studies in this regard. Then coming on to the next phase of our study, when we thought, okay, Indian studies, there's not much of evidence, but then if you see the whole global evidence if there is evidence, and we can draw some practice recommendations. So we, this umbrella review that we conducted on 97 meta-analysis that were published in last 5 years was done as part of the draft that we submitted for clinical practice guidelines, Indian Psychiatric Society. So apart from this umbrella review, we also reviewed other clinical practice guidelines like Royal Australian and New Zealand College of Psychiatrists guidelines, the neurophysiology, clinical neurophysiology European guidelines, and then the other umbrella reviews too, consensus and recommendations of APA, German guidelines on the use of rTMS. So apart from the umbrella review, we also reviewed other clinical guidelines and came up with these recommendations. So out of the 97 meta-analysis that we included for the umbrella review, majority of were for depression. 23 meta-analysis in the last 5 years were published, and we included them in our umbrella review. Bipolar depression 4, the unipolar, rest of them are unipolar. Bipolar depression were 4, treatment-resistant depression were 3, post-stroke depression 5, peripartum depression 3, depression Parkinson's also we included, so that is 3 in number, followed by dementia, schizophrenia, OCD, fibromyalgia, and chronic pain, substance use disorders, generalized anxiety disorder, PTSD, insomnia, migraine, ASD. Well, I'll come with what is the recommendation for each of these disorders from now on. And all these recommendations are based not only on the magnitude of effect size and the statistical significance, but also the 5 different domains which are recommended as part of the guideline, that is GRADE guideline, where in risk of bias, we reviewed imprecision, that is what is the interval of 95% confidence interval, how narrow or broad is that interval, inconsistency, how much is the heterogeneity, indirectness. So for example, studies, primarily outcome was, obsessive compulsive disorder there, but then they found out that improvement was there in depression also. That is indirectness. So we saw that as well, and then the publication bias in all these studies. Based on all this, we came up with something called a certainty of evidence for each of the disorders. Recommendation 1 is for unipolar depression. What's important here to note is that, for unipolar depression, high frequency rTMS, that is excitatory rTMS targeted to left DLPFC, has got strong certainty of evidence. So if you have cases of unipolar depression not responding well to augment in them, very well go ahead and use the rTMS, specifically high frequency rTMS targeted to left DLPFC. There is moderate certainty of evidence for low frequency rTMS targeted to right. So high frequency, use it to left DLPFC. You use low frequency, that is inhibited to the right DLPFC. That has got moderate level of evidence. Other paradigms that are used, that is bilateral rTMS high frequency plus low frequency both together, or bilateral TBS, ITBS plus CTBS together. Then ITBS, only ITBS over left DLPFC, deep TMS, priming rTMS. Priming is when you prime an area where you want to stimulate or inhibit initially with some excitatory stimulus. So that's priming. So all these paradigms have got low certainty of evidence. Bipolar depression and treatment-resistant depression, high frequency rTMS targeted to left DLPFC, which has got strong certainty of evidence for unipolar. Here, the certainty of evidence is moderate, but still there is moderate certainty of evidence for this. Pulses, 1,008. The studies have shown that more than 1,800 pulses can bring out more improvement in depression. Subthreshold intensity is what brings out better improvements. And less than or equal to 2 weeks treatment duration is okay. Now no need to give longer durations of treatment. Accelerated protocols so far have not been able to show significant efficacy than once daily. Saint protocol, which is Stanford protocol, which has got significant improvement, but then overall, if you see the overall evidence, it's not really better than the once daily sessions. Recommendation 2 is for peripartum depression, postpartum depression, post-TBI depression, and Parkinson's, depression in Parkinson's. In all of these, like bipolar depression, there is moderate level of evidence for high frequency rTMS targeted at left DLPFC. So the one which has got stronger certainty of evidence in unipolar, the same has got moderate level of certainty for all these 4 forms of depression that occur in other circumstances like peripartum, post-stroke, post-TBI, and Parkinson's. Like Dr. Shobit already told, even in peripartum, even if someone is pregnant, rTMS is quite safe, to be delivered. There is no Indian evidence on GAD, generalized anxiety disorder. There was no Indian study, but then overall, the research elsewhere tells that there is moderate certainty of evidence for use of low frequency rTMS to write DLPFC. And this is an important thing to remember. But it has not been shown to improve panic intensity. So it's in panic disorders. So among anxiety disorders, JADS, there is moderate certainty of evidence. For OCD and PTSD as well, it is the low frequency rTMS targeted to write DLPFC which has got the moderate evidence. So if there is anxiety component in any of the other disorders, like OCD is not now considered as an anxiety disorder, but in cases where the anxiety is quite predominant, then low frequency rTMS targeted to write DLPFC. So basically what we are looking at is the right DLPFC for anxiety and left DLPFC for depression predominant. Right, the number of pulses may range from 800 to 1200, which is well within the safety limits. 10 to 30 sessions, up to 30 sessions may be required in these cases. Unlike depression, where only 2-week sessions, where maybe 10 sessions or 12 sessions may be enough. But here, in cases of GAD, OCD, or PTSD, sessions which are required may be longer than that. Number of sessions may be more. For schizophrenia, now, there is low certainty of evidence for use of rTMS, especially low frequency rTMS targeted to the left parieto-temporal cortex for resistant auditory hallucinations. On the same hand, high frequency rTMS for left DLPFC, the same protocol which we use for depression, has found to be having moderate certainty of evidence for negative symptoms. So positive symptoms, rTMS may not work really well, unless you have a different protocol if you want to work on. If you want to give it in the clinic and there are predominant negative symptoms, go ahead and try, high frequency rTMS targeted to left DLPFC. Sessions again can be 1500. Now more than 10 sessions may be required, and supra-threshold stimulations may be required in these cases. Sub-threshold for depression may be enough, but cases of schizophrenia, supra-threshold stimulation may be required. Substance use disorder, in Indian studies, alcohol use was found to be having significant improvement, but if you see the global evidence, no, alcohol use craving, alcohol is not much of evidence available, or it is insufficient or negative evidence. But for substance, especially nicotine use disorder, smoking, there is low certainty of evidence for high frequency rTMS targeted to left DLPFC. Recently, FDA has approved, a deep H coil, that is H4 coil for smoking cessation. Not much of research has underwent on that. So maybe we understand in some time we can get positive evidence by use of H coils for smoking cessation as well. Alzheimer's dementia, high frequency rTMS targeted bilateral DLPFC. So both the dorsolateral prefrontal cortex may be excited by using high frequency, or high frequency rTMS only to the left DLPFC. In both improvement in global cognition as well as the behavioral and psychological symptoms of dementia, it has been shown that there is moderate certainty of evidence for use of rTMS in this. Now, other symptoms, not now diagnosis over, say, for example, insomnia. If there is insomnia predominant and it's not, other pharmacological agents or CBT-I is not working, then maybe we can go ahead and try using low frequency rTMS targeted to write DLPFC, basically, the one which we use for anxiety. So that has been shown to have moderate, certainty of evidence. And also for migraine, the area is primary motor cortex. I understand that migraine may be neurological disorder, but I also understand that there are significant patients of migraine that psychiatrists, we see them. So if you have an rTMS equipment with them, why not go ahead and use that? So the target is primary motor cortex and high frequency. So you need to excite the primary motor cortex for both migraine as well as fibromyalgia. For migraine, there is moderate certainty of evidence, but fibromyalgia, it is low. Now, chronic tinnitus, again, we included this in the meta-analysis because ENT, where they predominantly go, they may come to you as well. ENT people may not have rTMS with them. So in collaboration with them, or if you have cases directly coming to you, we can use them. The target is primary auditory cortex. So it is left auditory cortex, where low frequency, we need to reduce, we need to inhibit the excitation there. So low frequency rTMS targeted to primary auditory cortex is what is recommended, but with low certainty of evidence. So this is a summary slide which tells us what all available positive evidence and indications are, and then where insufficient or negative sham control evidence is. So depression, unipolar, bipolar, treatment resistant, peripartum depression, post-stroke, depression associated with Parkinson's, generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, schizophrenia, nicotine use, dementia, insomnia, migraine. Yeah. So these are the ones which are positive. Rest, suicidality also, there's not much of, evidence. What's important is, if there is suicidality, no way, go for ECT, don't look at rTMS at all. Because most of the studies have been indirect. They've seen cases of depression where suicidality has improved or not. So in cases of suicidal, no study has directly gone and used, except for some studies which are coming off late, which are accelerated protocols. Rest of the studies don't have sufficient evidence. Now, all this comes with one caveat. And this I have taken it from the update to the clinical neurophysiology European guideline. It says that current recommendations are based on differences reached in therapeutic efficacy of real versus sham protocols. That's what we did too. Replicated in sufficient number of independent studies. But this does not mean that the benefit produced by rTMS inevitably reaches a level of clinical relevance. So this is very important. What does that mean? That the evidence so far in use of rTMS is still emerging, not thorough. More research is required for preparing comprehensive algorithms for the implementation for the use of rTMS across different disorders, especially different phases of illness, various subsamples, etc. Right? And so what does it mean? So it means more utilization and documentation. Like Dr. Kaustubh in his introductory remarks told us, it is underutilized in India. Absolutely correct. Because if you see the total number of publications globally, this is Zhang et al. In 2020, where they have formulated how many number of publications have come on rTMS from 2009 to 2018. That is roughly around 3,000 articles. So every year there are around 350 articles now coming up. But from India, we are yet to reach 20. So that means that there is the research as well as utilization is quite less in India. So we want more utilization, documentation in form of research, unless you document, whether you utilize or not, whether it will not be useful for others. So that is needed from Indian studies. So we all who are in practice, if you can afford, like, Dr. Shobit gave you a cost analysis of it, it's quite cost effective, even if it's an expensive machine. So we need more utilization of rTMS and documentation from it. Regards from Hyderabad. Happy Onam to all of you, and wish you a happy Visarjan, Ganesh Visarjan, which may be happening today or tomorrow. Thank you so much.
Thank you so much, Shobit and Shai. Wonderful presentation. For the chairpersons for their opening comments.
Kaustubh sir, is he there? Yeah. Thank you, Sai and Shobit sir. It was a very lucid and comprehensive presentation. And you gave us very insights into where what the evidence is and how to go about it. These are all things what Shobit sir has mentioned. We only have studied but not have any hands-on experience. But it was very nice of him that even the Shobit sir has even explained that pulse also. So it was very nice to listen to you both. And I now invite my co-chair, Dr. Kaustubh sir. Is he here?
Yes, sir.
Sir,
I'm
please.
here.
Yeah,
Both the presentations were actually great. But again, I would reiterate the fact that without any hands-on experience, I myself feel very handicapped, because the knowledge I gained today, I will not be able to utilize it neither in my institution nor in my clinic. But I definitely hope that NMC someday will mandate its use for.
Kaustubh, you have gone mute.
So NMC will mandate its use for postgraduate training, and we will be using it all in our institutions. And as Dr. Sai has indicated, that there is very few researchers from India which is generating every year. So we need to focus on using rTMS in all those clinical indications. It is definitely a thing which is apart from the new psychopharmacological armamentarium and non-pharmacological treatment. Apart from those two, this is definitely an addition to our armamentarium, which has very less side effects and can be used with great ease. And Dr. Shobit made it very easy for all of us, particularly the postgraduate trainees who are viewing this session. So with this brief remarks from both the chairpersons, I would like to open the session for question and answers.
I'll ask the first question, Alim, if you permit me.
Always, always.
So Shobit,
Yeah, you are the moderator.
with due permission. Shobit, if you need to use rTMS, how convinced are you about rTMS? And what are the conditions if you have the illness, what would you prefer? In which conditions you would prefer to take rTMS? Same question to you, Sai also.
So taken back to our college days, sir. Sir, basically, sir, I'll use it not as a first preference. I'll actually save it mostly for patients who have not responded to conventional agents as per clinical staging model. Then this becomes one of the reasons where that is why in many patients it doesn't work, because most of us will reserve it as a third, fourth, fifth treatment option. So already refractiveness is there. So how we expect, out of the blue clinical benefit that appears in a patient, except in few clinical scenarios like pregnancy and all. So, sir, I will use it in only like in depression, schizophrenia. I've been using it in OCD, but we are actually utilizing the designing research protocols, and those refractory patients actually we are trying to inculcate them in these paradigms. And as it is blinded, so we don't know which of the patients have responded.
So I will have a little different take on this. Most of the research, whatever I have gone through, reviewed, and even in the practice which I had during my stay at Central Institute of Psychiatry, treatment resistant cases most likely won't respond very well. So I'll not wait for the treatment response to come, treatment resistance to come, but then I'll not use it as a first line as well, like as what Dr. Shobit will do. So I'll go for the conventional treatments, pharmacology, maybe CBT along with that, whenever it is possible. The next, I see that there is not really much response, or more response is required. If I have the equipment with me, I'll definitely go ahead with rTMS, especially if the case is depression. Depression, there is strong evidence that it works, and especially in unipolar, there are now some researches that are coming up where they have used it as single option as well. It's not as an augment, but then as singular. I remember with Dr. Prasenjit, we conducted we used rTMS for auditory hallucinations in schizophrenia. And also that too, we did not see resistant auditory hallucination. We saw them early in the treatment as only. So early in the treatment, in the recent onset cases of schizophrenia too, there is evidence that it might be helpful. Like overall evidence says that schizophrenia for auditory hallucination may not. But then if I have an option, and if I see that they're not really responding the first line, then I would go ahead and augment with rTMS initially. I'll not wait for the treatment resistance to happen and then use rTMS.
So you will use it as an augmenting agent, not as replacing one line. Suppose you started on a SSRI.
Yeah.
So if you look at depression, you start on an SSRI.
Yes.
So you augment it.
There is enough evidence which suggests that when used as an augment, say for example, I am using escitalopram plus rTMS, and then only escitalopram. So this is one case where rTMS with escitalopram is better. If I'm using only for some reason, say only rTMS is going on. So compared to that, cases where escitalopram and rTMS are going on, I expect better results in them.
I'll please continue. Alim, or a question, if you don't mind. So when do you decide, should I change, suppose I've started an SSRI, should I change the class or should I add rTMS? Now, how do you decide?
If we classically go by the steps, we see partial response. We feel that there are still
what I'm asking, do you understand?
Yeah.
So हमारे पास option है, SSRI के बदले दूसरे SSRI दे सकते हैं, एक class change कर सकते हैं, augment कर सकते हैं, rTMS add कर सकते हैं. When would you like to? What are the patient?
So add on, if I'm saying
patient when you want to add rTMS.
Yes. So if I decide for a replacement, say for example, if I want, there are not quite side effects or something, I want to replace, or there's no effect at all, I want to replace one drug with other, I would go ahead and do that. I'd go ahead and do it and add some other agent. But then when I feel it's an augmentation is required, then I'll go ahead with rTMS. If seeing other things, availability,
Partial response, then you let it.
Yes.
Partial response.
Shobit, what would you like to do? Then we'll open it.
Sir, I'll actually say many of the things depends upon patient's choice also, sir. You have to actually be very clear about it. Many patients, they read rTMS and they're fascinated by it. One failed trial, they might not go for another trial. And one of the important factors of, sir, failing the trial can be a poor tolerability of the drug. So drug is poor tolerant. We have a lot of patients who even can't tolerate 2.5 milligram of escitalopram. Very sensitive. So they have an aversion towards drug therapy. CBT might not be available in places like us in Dehradun. So when we have this unit, so we'll try to actually counsel and take those patients to there. It justifies and also probably brings benefit to them.
Okay.
Like a corollary to it, Kerala is the most advanced state in terms of psychiatric care. If you look at the number of psychiatrists, if you look at the penetration of psychiatrists. So Dr. Philip John has an interesting observation. So just to adjust, you, like you told, people won't have psychotherapy units. So he has told that Kerala is yet to open a center with rTMS, critical people. So how confident one can be to open a center with moderate promise of release for patients and fairly good return on investment? And what is the promise for its future in psychiatry? Sir is asking again a corollary, how much would it cost me to set up a good facility, including personal and training? Where can I get a psychiatrist trained appropriately in the South? How long would be reasonable on hands-on training? There are a lot of questions people wanted to ask. I think that's why Alim had told you to talk about costs. Dr. Philip sir is asking about how to set up a center and all that. So you please, then Alim can answer. Summary your question.
NIMHANS does 3 days annual training program, sir. वहाँ पे they can get the training in license with the IPS. So there it is in Bangalore. So that is a very good, accessible and state-of-the-art facilities they have. And as we discussed in the cost analysis, standard foreign-made rTMS machine with theta burst would cost around 20 to 25 lakhs. And that actually with very minimal charges of rTMS, like 250 rupees per session. So, you know, many of the newer drugs are coming at 70-80 rupees per tablet. So and these sessions will happen around 15 sessions or around 20 sessions in 2 weeks. That's all. So that can be pretty affordable. And as a investor, I'll record my cost also.
Shobit, just a small point here. If Amrit is through, Amrit?
Yeah. You're so impatient. I wanted me to be through first.
Shobit, regarding your cost analysis, you have just calculated the cost of running up the machine.
Yes.
Recovering the cost. When you calculate, I'll add certain things here. When you calculate the cost, you have to take in account the staff that is running, the consumables, the setting, the building, the AC, all the things, and the maintenance cost. And most important, if God forbid you are fined by consumer protection, you will charge 1 crore or 10 crore penalty. So all these things should also be incorporated while taking the cost. So the cost of running a machine is a bit less, but if you take all these factors, I think cost would inflate a bit.
And the AMC also. AMC has to be added to that.
Correct, sir. We have a Mac Pro unit here with no maintenance till now. We are running it the 6th year. Our coil had expired, so we got a newer coil. But that includes this cost analysis, number one. Number two, in a busy clinic OPD, a private practitioner's OPD, must be having staff of around 4 or 5 people, including one nurse or a technician. So that can be trained. And then can be the operator. And myself, if I go for some certification course, I will get trained in rTMS. So that would suffice for the cost, because it will just consume one additional room, and you can actually give rTMS while sitting in a stool also. So in that context, it will not add a huge amount to the expenditures to a running clinic. Someone who opens it, who is actually sitting in an area, who has opened his new clinic, is waiting for the clientele, it might be a struggle for him. But I think for someone like Dr. Amrit and Dr. Alim sir, it must be a cakewalk.
Yeah, I just want to add one thing here. When we talk about consumer protection and lawsuits and all, so most practitioners now, when someone calls me and asks me, I want to set up an rTMS clinic, which is a machine that you need to, there is Medicaid available, there is RNS, there are other systems that are available. I always tell them that, go for, if it is possible for you, if your practice is good, go for the ones which are approved, approved by FDA. because there is no regulatory body in India which regulates RTMS system so far. So if in case I take Medicaid, right, and then, unfortunately, God forbid, if there is a seizure and then, any other any subsequent complication occurs, and if case is sued, and then maybe the chances of you having to pay more in case of Medicaid is, higher than if you have, an approved system with you.
Okay.
So, it can be a little different, may interfere.
Yeah.
So one has to have a decided guideline when to choose rTMS. Because if I choose a method of treatment and there is an adverse effect, I am not liable by the Consumer Protection Act. If I can justify in the right perspective, with the right history and with the right documentation, I have chosen rTMS as the treatment at that point of time, and all alternatives has been also explained to the patient, and he has agreed on this. So,
yeah,
is there
so
any
the point
guideline?
which I want to make, sir, is that, so for example, if I'm using a Medicaid, which has got no regulation, we don't know the safety parameters which are associated with it. So for example, if the patient gets to know that this is the equipment which is not approved, then that is a case where actually giving a note on.
About suppose we have the foreign ones which have been approved in their countries, right?
No,
not even
so
in India.
actually,
My point is that even if we use that we can give rTMS to this patient. Do we have clinical guidelines? And in this condition, we have to give very clear clinical guidelines, which will be very much protective.
Indian ICMR and CDSCO, they actually follow FDA directly if there's no other separate regulation.
Okay. Okay, Sai, a practical question, Sai and Shobit, whoever wants to take it. Do you have to determine this motor threshold every time, or once it is done, it is done?
I think this is an important, very important question, sir. So, what happens is, if the parameters remain the same, say, for example, parameters means in terms of the drugs that person is using, the sleep the person has had over the last week, if the parameters are more or less the same, then the same MT can be used for up to a week. So, if I'm using 5 sessions in 1 week, that MT can be used to determine the intensity for those 5 sessions. Now, if for the 6th session, which I'm starting the next week, I would ideally want, new MT to be determined. Ideal situation is I MT before each session, right? But then, in feasibility wise, I would say 1 week, but if there is any change in the medication status, or if the person has had the alcohol the one evening before, or has not had enough sleep the one night before, then I would like to determine the MT again before I give the session. Yeah, I mean, yeah, these are some situations where I can understand, but then there are
because Sai is right, because calculating motor threshold can be deterrent in using rTMS. It's not very easy. It's very difficult and tedious process, and we need a lot of anancastic traits to execute it. So better is we do it in a week window. We take advantage of this probable thing, this leeway which they have provided. Maybe in few months or years, they will take it off and they'll say calculate motor threshold after every stimulation. So till now, we can do it in a week.
Okay. Prashant wants to ask how many sessions, I think you have partially answered it also. How many sessions efficacy develops, because patient would be reluctant if no therapeutic develop.
I mentioned that in the recommendations. For depression, it said that 2 weeks is enough. 2 weeks means everyday session, maybe 10 to 12 sessions if you give 1 day off, right? That is enough for to improvement in depression to start happening. And in fact, that we stop at 2 weeks, and then where is the need to continue sessions is where where in conditions of GAD, OCD, wherein we continue the sessions up to 30. Some people have given, there are case series from India to where there are up to 50 sessions given, wherein we see what the response is up to that particular time. There is a response is coming on after 2 weeks, then wait, give 5 more sessions the next week, then 5 more sessions the next week. If there is a trend of improvement in the symptoms. In cases of OCD, GAD, and PTSD. PTSD, there's not much of research from India, but then that is what the guidelines suggest.
So how much time is consumed in giving all those sessions? And
so actually, if I give one session, one session per day.
Yes.
One session per day, starting from determination of motor threshold, doing some checklists and also patient preparation and all that. Roughly, I can understand it. One session will take around 1 hour, like 45 minutes to 1 hour time. The high frequency stimulation will happen very faster. And if I'm using a TBS, the stimulation time is much less than the conventional high frequency or low frequency. But then more than the stimulation per se, the time that is spent in preparing, and then those checklists and seeing that, I remember low frequency for longer pulses, longer time, the coil gets heated up very fast. And then I have literally seen that, standing just beneath the AC, waiting for the coil to cool down and then continue the sessions. So these are the time consuming things. What's important is a good AC, roughly around 40 minutes to 1 hour, I guess, for each session.
okay, Amrit.
I will take some rapid fire questions. Okay.
Rapid, yes.
So anybody can pick up. Is there any evidence for improvement of cognition?
Yes. Yes. So there is evidence, but that evidence is still insufficient. There is an umbrella review by Hyde, which has seen cognition in Alzheimer, cognition in schizophrenia, cognition in depression. There is some evidence, but still the evidence is insufficient. In fact, not only in cases of psychiatric disorders, but in healthy controls also, rTMS has been used to improve cognition. In certain situations, and if someone wants to, situations like chess playing, and if it can improve attention and all. There is evidence, but then still insufficient to say that it can be taken to clinic.
How does it compare with TDCS?
So a corollary to this question: if it is given to a normal person, what will happen? There's a question in the chat box. Then I'll push.
So it would bring about the same changes that if I take maybe, if I'm normal mood euthymic, and if I start taking if I'm not predisposed to having a bipolar disorder, and if I take escitalopram, the same time kind of changes it might bring about.
So there are a lot of data where the rTMS protocols have been given to normal population to study. It's an online paradigms to actually study neurophysiology. So they'll actually create an hotspot in some area of the brain, and then they'll calculate the perceptual speed, the set shifting, and they'll actually establish that brain area is involved in XYZ function. So that is how. So the amount of stimulation, inhibitory, excitatory, and we'll expect the neurophysiological changes in that person.
So suppose if we assume that Aleem is normal and you give rTMS, so will there be any benefit?
Super normal.
Sai, any evidence for anorexia nervosa?
Yes, there is evidence. There is a recent meta-analysis which we included in that, but then again, it doesn't tell that there is significant evidence. That is why I did not include that in the recommendations. Other condition where there is evidence, but then we couldn't formulate recommendations is autism spectrum, because it's coming up big way in West. Even India would like to actually have. There are parents who actually want to try out rTMS in cases of in the children with autism spectrum disorders. Problem with the current evidence is that multiple brain areas have been stimulated. In one case, frontal, occipital, parietal, all three have been stimulated. In some cases, only bilateral. So there's no homogeneity in the target location. So that's why we couldn't formulate any particular recommendation. But then it is coming up. There is evidence that is accumulating in autism spectrum and anorexia as well. Anorexia, actually, all compulsive disorders like say alcohol, to wherever there is addiction, there is eating disorders or consumption related disorders, rTMS has been tried.
Okay, how does it compare with TDCS, pros and cons?
So comparative studies with the neurology studies, there are a lot of studies in where they have compared TDCS with TMS. In psychiatry, there are not lot of trials, occasional trials of their within efficacy, or they have actually said no efficacy, kind of a thing.
There is
they're not found superiority over each other.
There is one analysis which actually compared ECT, rTMS, TDCS together also. while ECT has got significantly better efficacy when compared to rTMS in those cases. That's what they found out. In compared to TDC, so there are some conditions, I guess, I think dementia where the efficacy of TDCs is better than TMS, and rest is more or less the same, I guess, because that is what. But there are not much studies which are having had. There are mostly network analysis, network meta-analysis kind of studies.
The cost difference between TDCS and rTMS? TDCS appears to be much cheaper.
Very cheaper and
So we
easy.
can take up.
Much cheaper.
Yes.
Yes, sir. Yes.
Any medications
So
that
when we are going to place it in a clinician's chamber, that is also important factor.
Yes.
any medications that change the receptivity of brain for TMS? Increase seizure threshold, decrease seizure threshold, any effect is there?
Yes, alcohol,
So, like,
benzodiazepines, classically the ones which we look at in
दारू पिला के rTMS दोगे क्या?
दारू पिला के rTMS देंगे तो ज्यादा इंटेंसिटी जरूरत पड़ेगा.
Oxygen, like we give in ECT?
Like
No,
all the psychotropics, sir, which would reduce or increase or decrease the threshold will play with your motor thresholds. So you'll have to actually customize it as per.
Alim will take the last question. What is your opinion about SAINT, a rapid acting rTMS which compresses the treatment to just 5 days? Then
Yeah.
we'll add it to
Actually, SAINT is a rare trial. One trial which was published, what they did was 18,000 pulses were given in one day, and they compressed 50 sessions were compressed in 5 days, and they actually found significant improvement at the stimulation point, and they found significant improvement. But they said that this needs more replication. This was done by one group. So actually, personally speaking, I welcome that because you are saving time.
I smile for the first time.
You're saving time. You're saving time. You're giving theta burst stimulations, which one session will require 1 to 3 minutes. You're saving patients time, and the overall follow-up duration becomes less. So it's a less economical burden to the patient also.
Yeah, I mean this Stanford, Stanford accelerated intensity. I don't remember the exact the full form. They took up around 20 cases of treatment-resistant depression. So they saw treatment-resistant cases of depression, and by the end of the session, they found out that 19 out of 22, I guess, if I don't, if I'm not.
It's an open-label trial.
Yeah, it's an open-label trial. There was no sham control. They found out 19 out of 21 or 22. They found, I mean, they remitted. In fact, they met the criteria for remission after the completion of the sessions. So it's a rare thing which needs to be replicated. It's just one study which is uncontrolled.
One question which everybody is asking is, where can they get training for rTMS? So you can conduct workshop like Dipan, my close friend, has been asking. So
yeah,
you can go and do it there.
One
So
addition,
there are yes.
The Course and Certification Committee of IPS is planning on running a certificate course for this rTMS. So that is one addition. I think Nimhans is running it.
AIMS New Delhi has also, in collaboration with
CIP में भी
IPS.
होगा नहीं है?
Sir,
CIP?
CIP, I think they have started. I am not very sure of recent developments because there's a combined study between Niman, CIP, and Kasturba. They have a big funding from DBT. So I guess they are doing clinical research training in rTMS, which is for around 1 year or 6 months. But certification course for operators and physicians, I guess, I think Niman's and AIMS I know of.
Thank you.
We get to the chairpersons now.
Yes.
Final remarks, chairperson, sir.
I think Dr. Deepan Sarkar has raised his hand. He wanted to ask some questions.
I think I took his question.
Did you, sir? Okay. So.
Yes, sir. Can I ask something, sir?
Yeah, Dipanji, bolo.
Sir, I may be the last one to ask something. What are the institutes that we can send our friends or we can come for some training, and for how many days actually the training needs to be done to run or open a new setup? Is there any answer of that, sir, or anyone can help? To both the speakers, anyone, sir?
So actually, Remance is running a 3-day program. annual 3-day program. So and it depends upon the person who the institute who wants to deliver that course of the rTMS. I think 2 days or 1 day course is suffice, but given
So-
that we subsequently follow it up with some quality control or monitoring.
Okay, sir.
Sir, we can hold one workshop at your place only. We'll come there and hold the workshop there. The Pan bus. So,
Yes, sir. कर देंगे सर, कर देंगे, कर देंगे. कितना दिन का चाहिए होता? 3 days का होगा सर?
3 days good enough.
हो जाएगा. 3 days 4 nights.
Sir, we attended a workshop in AIMS Delhi. That was a comprehensive workshop which they encapsulated in 1 day.
Dr. Pawan.
Okay, sir.
Thank you, Dr. Shobhit.
Okay, sir. If we hold some conference or something, then definitely we'll try for that, sir.
हम लोग बुलाते क्या संडे ईस्ट जोन का कॉन्फ्रेंस में बुलाते एक वर्कशॉप करते हैं. चलो.
Sure. Dr. Pawan.
Thank you, Dr. Sai and Dr. Shobhit sir. It was a wonderful presentation, and you have given us the total overview. And now, Kaustav sir, if you can make a quick final comment, we will hand it over to the.
I think Kaustav has just his net has dropped.
Okay.
Yeah, he's there. Kaustav, I have unmuted you. Yeah.
Yeah. So all the questions have been answered and nothing to add. It was a wonderful session. In our state, I can vouch that only Gautam Da has rTMS in his clinic and nobody else. So definitely we need 2 or 3 days training. So people get motivated to procure rTMS and apply it to their patients. It was a wonderful session. So Thursday Musings definitely is a worth watching show. Thank you.
Thank you. Sir.
Sir, over to
Tufan.
Tufan sir.
Pawan, you don't have any comment?
I have made my comments.
Okay, thank you.
Yeah.
So I always favor new treatment modality that come. It has to be seen, tested, and one opinion has to be developed. And both rTMS and TDCS have a scientific basis. Maybe we are not very clear about that. Maybe you have to know much more about that. How to localize? Can we be specifically more localized than we are becoming? And it is welcome. This is not costly when it is 20 lakh. New innovation, 20 lakh is nothing. Or most of the gentlemen who are here can easily afford 20 lakhs. Training is important. Training in 3 days, how much it potentiates, time will tell. But though the centers, Manipal, CIP and NIMANS who are in charge and who should have regular workshops peripherally so that more people will be interested. And very good, and it is a very dynamic presentation. I had discussed with Shobhit about 2 months ago. Now it was fructified. Thank you, Shobhit, and thank you. Bye.
Thank you, sir. Thank you, sir.
Thank you, sir. Amrit, over to you.
So we had a world-class presentation today.
Yes,
धोनी का इनिंग्स दिखते लगा. आज विराट कोहली सेंचुरी मारा और साई भी यहाँ सेंचुरी मारा. शोभित पीछे से he set the game up. So brilliant presentations, wonderfully answered, and you were very objective about it. Just because you had 10 papers, you did not tell that rTMS is the solution to all problems, and that's what we always need. You answered a lot of questions we wanted to ask before we asked. So all in all, it was worth our time. We had, even though it was a corely medical issue, we had so many, more than 180, 190. Today being Onam, I think that's really wonderful. Pawan Bhai, my Captain Saab, was wonderful. Kaustav, dear friend, it's a brilliant unit today. Thank you, Tufan sir. Thank you, Alim. Thank you for allowing me to ask some questions today. Generally, you never allow me to ask questions. He'll be firing. He will not even look at me.
I'm actually surprised when you say that, sir. Actually, you are the more aggressive. We have been following Thursday music for quite some time now. So,
I appear to be aggressive. I'm not aggressive. Thank you to all viewers, we will be bringing more
We
fresh.
look at Alim sir and Amrit sir as like Kohli and Dhoni. So
Who is the Kohli? Who is the Dhoni?
you are the Kohli boy.
Always the Dhoni fan. So good night.
Good night, sir.
Bye bye.
So
Thank
much,
you,
sir.
sir.
Thanks, good
Right,
night.
thank you.
Thank you, everybody. Good night.
Tufan sir, thank you, sir.
Right.
Have-
Closing.
See you soon sometime.
Bye, sir.
Bye, sir.
Bye, boss. Bye, bye.
Alim sir, bye, sir.
I had
Right.
visited in detail the CIP Neuromodulation Center.
Sir.
Got see Dr. Umesh spend around